You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Barbara Zoltick, nurse practitioner at the University of Pennsylvania in Philadelphia, and member of the Bucks-Montgomery Counties ONS Chapter, to discuss treatment for patients with advanced and metastatic urothelial cancer. Seattle Genetics Incorporated provided support for this podcast episode through an educational grant. Thank you for joining me today, Barbara.
Good morning, Stephanie. Thank you for having me.
So to get us started today, will you please tell us a little bit about urothelial cancer?
Urothelial cancer is a cancer of the urothelium, or the lining of the urinary tract. Most people kind of think of it as synonymous with bladder cancer because 90% of urothelial cancers do occur in the bladder, although 10% arise in the renal pelvis, the ureters, and the urethra. There are other kinds of bladder cancers, squamous cell, adenocarcinoma, and small cell, but they are treated differently and not really going to be part of the conversation. Bladder cancer can be a fairly aggressive cancer. About 5% of patients may have it at diagnosis, may have metastatic disease at diagnosis. The 5-year survival rate for patients with a localized disease can be 70 to as high as 95%. For patients with regional disease, that drops to about 35%. And unfortunately, the 5-year survival rate for patients with metastatic disease is only about 5%. And there is no approved screening like there is for prostate or bladder cancer.
Is this a common type of cancer?
It's not a high-profile cancer. People don't think of bladder cancer when they think of common cancers, but it is the 6th most common cancer in the United States. There's about a little over 81,000 new cases estimated this year, and almost 18,000 deaths are expected.
That's very interesting. I have to say that I didn't realize that it was number 6 on the list. What patient populations are at a greatest risk for urothelial cancer?
It's most common in older middle-aged patients. It's very uncommon before age 40, and I think the average age is about early 70s. It's about 3 times more common in men than it is in women, and for reasons that aren't clear, it's more common in Caucasians. There are risk factors which include patients who are smokers. That is the most common predisposing factor. Exposure to occupational heavy metals and hydrocarbons. Even patients who have received prior cyclophosphamide, possibly breast cancer patients, pelvic irradiation, and also some genetic predispositions.
What are the typical presenting symptoms for these patients?
The most common presenting symptom is gross painless hematuria, blood in the urine without other symptoms. About 85% of patients present with gross hematuria. The thing about it is it may come and go, so it's something that should always be followed up. Just because you had hematuria yesterday and don't have it today doesn't mean everything is okay. And also some patients will present with what we call LUTS, L-U-T-S, lower urinary tract symptoms, very similar to symptoms of a UTI, or urinary tract infection.
So things that could be very normal, or, well, I shouldn't say normal, but something that somebody might not think that this might be a really severe or symptom that needs to be looked at sometimes, especially maybe you have a patient that has had a history of UTIs. So for them, they just think it's experiencing a UTI again. But how important it is for these patients to get checked out.
Exactly. It's very important with chronic urinary tract infections. Sometimes you'll go to a provider and they say, oh, it's another infection, and treat it empirically instead of working it up and seeing if it isn't a urinary tract infection. Well, then maybe we have to find out the cause.
Right. How is localized disease treated?
Well, localized disease can be non-muscle invasive, meaning that the tumor does not go through the detrusor muscle, the muscle of the bladder, or muscle invasive. So non-muscle invasive disease is treated with a TURBT, transurethral resection of the bladder tumor. And that can be immediately followed by intravesical chemotherapy, generally with gemcitabine or mitomycin, and that can often be done right in the recovery room. It should be done within about 6 hours. That can reduce recurrence by about 35%. For higher grade cancers, BCG is localized immunotherapy. BCG is a weakened strain of the Mycobacterium bovis, and you need to be healed up from a TURBT before you can receive that, usually about 3 or 4 weeks. Unfortunately, there's currently a BCG shortage, so it is being reserved for the higher grade cancers. Once localized cancer is no longer superficial and invades into the bladder muscle, the gold standard is a radical cystectomy and diversion, removal of the bladder and diversion of the ureters so that the urine can pass out of the body. This is usually preceded by neoadjuvant chemotherapy prior to the treatment of curative intent, which does decrease the chance of recurrence and increase the chance of cure. Partial cystectomies are done in very selective cases, usually when the tumor is at the dome of the bladder. And for patients who are unwilling or have comorbidities that contraindicate major surgery, they can undergo chemo-radiation combination. But again, a radical cystectomy is the gold standard for muscle-invasive disease.
So when you were talking about the localized disease, what would differentiate a localized disease diagnosis versus advanced disease? What would that difference be?
That's a good question. So localized disease is disease that is in the bladder itself. Maybe prior to surgery, it involves a lymph node or two. Advanced disease is disease that is metastatic or that recurs following treatment of curative intent, disease that is no longer curable with surgery.
Now that we understand what advanced disease is, what would the most common treatment for advanced disease for these patients be?
First-line treatment for a patient that was just diagnosed with recurrence or metastatic disease, advanced disease, is one of two regimens. One would be gemcitabine and cisplatin, GC, and the other is methotrexate, vinblastine, adriamycin, and cisplatin, which is also known as MVAC. MVAC is a much older regimen. They're both equally effective, but the gemcitabine and cisplatin is generally more tolerable. And they're usually treated with about 4 cycles of chemotherapy. Or one thing I forgot to mention is that for patients who have renal insufficiency, because of the nephrotoxicity associated with the cisplatin, patients with poor renal function generally are not candidates to get cisplatin-based therapy and can actually go on to immunotherapy.
We've talked about localized disease treatment and advanced disease treatment, but when patients are diagnosed, is it more common for them to be diagnosed with localized disease or in an advanced stage?
Most patients are diagnosed with localized disease. About 5% may have metastatic disease at diagnosis.
So we talked a little bit about the 2 common regimens that you mentioned for advanced disease. What are some of the challenges that nurses would encounter when administering these treatment regimens to patients?
During infusion, both the gemcitabine, cisplatin, and MVAC are generally well tolerated. There's not usually much of a problem with allergic reactions or nausea, vomiting, or anything during the infusion. They both utilize cisplatin, so it's very important to make sure that they check a stacked creatinine and the patient's urine output before they start the chemotherapy. It's important to monitor ins and outs and watch for signs of a possible fluid overload. Gemcitabine, although it's not a vesicant, it's an irritant and it can burn the vein, so they do want to make sure the patient is comfortable and there's no infusion irritation. Now, MVAC utilizes adriamycin, which is a vesicant. So they should closely follow the hospital policy for administering vesicants and monitor for infiltration if it's going through a peripheral line. With pembrolizumab, which is we haven't talked about yet because that's not generally for first-line treatment, although it is for patients who have poor renal function. One of the challenges for nurses is the possibility of an infusion reaction. They're not common. Less than 0.2% of patients have them, but when they do have them, you have to be ready. So if a patient has rigors, chills, wheezing, rash, hypotension, any of those type of symptoms, a sudden onset of fever, have the reaction protocol ready at hand so that the patient can be immediately treated.
Are there treatments normally given on an outpatient basis, or are they admitted as an inpatient and given these regimens? How does that normally happen?
These are generally, I would assume at most institutions, outpatient treatments. Gemcitabine is a half an hour, and together when you're adding the fluid regimen to these, probably takes 4 or 5 hours for the infusion. So it's something that can certainly fit into an outpatient regimen. It's important to remember that both regimens, both GC and MVAC, require IV fluids pre and post because of the nephrotoxicity of the cisplatin. So you have to make sure that in your infusion unit, you set aside enough time to allow for fluids before and after.
So because of that, and as you've been mentioning how important it is for that fluid intake for patients, the IV fluids before and after, what are some of the really important teaching issues that might have to be given for patients that are receiving these treatments?
Well, they obviously should be informed of any options, if there are any, and what the risk benefit is. They should know the schedule, how often they're going to need to come in. For patients who live far, they have to make preparations for the trip. They also obviously need to know what the side effects are and how to manage them. For cisplatin-based therapy, they need to know particularly about managing signs and symptoms of nausea and vomiting, how to manage their antiemetics, what antiemetics will be given. Hydration is extremely important with both of these because, people say, oh, that's fine, I drink plenty. But once somebody gets nauseous, even if they're not having vomiting or they're tired from the chemotherapy, it's an effort to get up and get something to drink. So different strategies for hydrating is important. For patients undergoing immunotherapy, they need to know to watch for rash, cough, diarrhea. And of course, as with any chemotherapy, for the MVAC and the Gem-Cis, they need to watch out for fevers, which could potentially be neutropenic fevers. And they also need to know when to call. And I always tell my patients, you call whenever you're worried, whenever something doesn't make sense. But make sure that you call if you have fevers, if you're unable to take in fluids, and just all the other potential side effects that are significant enough that they need to call for some assistance.
What would happen if the person's disease persists after their initial therapy, and what might be offered next for these patients?
Well, once initial therapy either fails or there's a recurrence, we go to second-line therapy. And in the past few years, we're fortunate enough to be able to use immunotherapies. So immunotherapies are immune checkpoint inhibitors, and they're generally well tolerated. The most commonly used one for bladder cancer is pembrolizumab, which is a PD-1 inhibitor. It's generally given at a flat dose every 3 or at a higher dose every 6 weeks. Although there are other drugs, atezolizumab, nivolumab, and durvalumab, which are also approved, but I don't think that they are used as often as pembrolizumab. If patients should fail that, there is third-line therapy. One is a new drug that's very recently been approved called enfortumab vedotin. It's a Nectin-4-directed antibody for those nurses who know more about this than I do. And there's also another new drug called erdafitinib that is specifically for patients with FGFR mutations, and it requires a biopsy and some immunohistochemistry so that you know if the patient is eligible for it. The other therapies are pretty much given to all comers.
With immunotherapy being newer therapies and showing good results, is there a reason why they wouldn't start with immunotherapy versus starting with traditional chemotherapy?
That's a very good question. And as I said before, if patients cannot tolerate cisplatin because of poor renal function, then they certainly could start with immunotherapy. But other than that, as of now, there has been no clear evidence that patients who are eligible for cisplatin-based chemotherapy, and we know how effective it is, we don't know if they would benefit from first-line immunotherapy. But that doesn't mean that clinical trials won't be done to see if that is a possibility in the future.
Okay, that's good to know. Well, you talked a little bit about educating patients with their treatment and the information that needs to be included when these patients are diagnosed and having that initial education session with the nurses. Would there be anything else specific to the immunotherapies and these new therapies that would be important for nurses to know about educating their patients with?
Yeah, immunotherapy certainly is generally very tolerable. And I think the most common side effect of immunotherapy is fatigue. But after several cycles, patients can certainly develop immunotherapy-related side effects. They're not common, but they can certainly occur. Diarrhea that doesn't respond to the usual treatments and needs to be treated with fairly high dose of steroids is one of them. They can develop damage to the thyroid gland and need to be started on thyroid replacement therapy. Pneumonitis is also a side effect, so you have to be very careful to watch for dry cough. Rash is also seen that can also be treated with steroids. We've seen patients develop sudden onset of insulin-dependent diabetes. And there's other rare instances of cardiac disease, muscle weakness, iriditis of the eye. But the most common is fatigue. But patients have to know that there's very little treatment for cancer that doesn't have the potential for some possible side effects.
That's so true. And for the nurses listening with us today, that's the other thing that it's so important with the new immunotherapies coming out and all of the new side effects and different side effects that patients could experience with these treatments. It's so important to make sure that you have good resources and you understand about these treatments so that you can educate your patients and also just be aware in case a patient calls in with something that sounds kind of out of the ordinary, let's say.
I always say to patients that, if they report something and I look and I don't see that it's been reported previously, I said, there's always somebody who comes up with a side effect that we haven't seen before.
Right. So true. And so it's so important. Like you said, I like how you said that you tell your patients if you're worried, if there's something that just doesn't seem right or feel right, to let you know, because that is so common with all of these new therapies coming along so quickly that there could be something that just maybe we don't know and we don't have written down, or with these combination therapies, even, having different kinds of side effects that pop up that are unusual.
And sort of post-marketing effects that get captured later on after the clinical trials are done and you're giving it to the general population.
Exactly. You mentioned earlier that a couple of the therapies that patients receive with this diagnosis are vesicants. Are there any other considerations for patients receiving vesicant therapy that you'd like to share with us?
If a patient has a central line, the vesicants are not an issue. But for patients who don't have a central line, and at our institution, we tend not to put in central lines unless they're getting a vesicant continuous infusion or they have other issues that require a line. It's very important to avoid small veins and listen closely tell the patient to let you know if something burns, if they're having any pain, if any swelling develops, and also if they notice any problem at the IV site once they go home. If there is any possibility of extravasation, I think ice is the way to go with these vesicants and should, again, follow your institution's protocol for vesicant infiltration. We do see in patients, as we all know, patients with any kind of cancer, patients receiving chemotherapy are more at risk for blood clots as well. And it's not unheard of for patients on cisplatin-based therapy to get not only DVTs, but superficial clots. So sometimes you can have a swelling in the arm and it's not really an extravasation. Interestingly, we had a patient the other day who got GemCis and complained about a lot of pain at the IV site during the gemcitabine. And the nurses checked and there was blood flow, but it looked like she had a bit of an infiltration. So they just told her to put warm compresses on it as opposed to ice because it was gemcitabine. And she went home and the swelling got worse. And I actually saw her a week later, just on Friday. She still had swelling and it was tender. And I sent her down for a Doppler and it turned out she did have a superficial thrombus in that area. So vesicants and irritation of the vein from the chemo are not the only reason that you might get some swelling at an IV site or on the same side as the IV was infused.
Thank you. That was a great example of something that could come up that, isn't what you might have been thinking about happening. So you've given us a lot of information today. I have a few more questions to finish us out, but one of them is, what are some common misconceptions about urothelial cancer and its treatment?
I don't know if there's misconceptions specifically about urothelial cancer and its treatment other than most people aren't aware of it. But, as it's not a whole high-profile cancer, as we mentioned, but patients sometimes in general overestimate the toxicity expectations of cancers. They think that nausea and vomiting is inevitable. So I reassure them that, there's always an outlier, but in general, in most patients receiving these regimens, we are fairly successful in managing the chemotherapy. I tell them, I can't promise you that you won't have any nausea, but if you have nausea that's unacceptable and you can't eat, or you're having vomiting, don't sit home and say, well, the antiemetic I got isn't working. I guess I'll just have to sit here and be sick, but always to call. I think patients, just the word chemotherapy is very frightening. On the flip side of that, patients also think that immunotherapy is very benign and that you get it and you don't have any side effects. So as we discussed before, it's usually fine for a few cycles, but there's always the potential of immune-mediated side effects that can also occur.
And what are some resources that you would recommend for both patients and for providers?
Well, for providers, you can never go wrong with the NCCN or ONS guidelines. They have guidelines not only for treatment, but also for some symptom management. Unfortunately, because bladder cancer is not a high-profile cancer, the NCCN does not have any patient support brochures. It has some for breast cancer, and colon cancer, and lung cancer, but not for bladder specifically. But they do have patient pamphlets for nausea and vomiting and some side effects for immunotherapy. The AUA, the American Urologic Association, has good support for healthcare providers. For patients, the American Cancer Society, as always, is an excellent resource. There's also some online sources, bladdercancer.net, Bladder Cancer Advocacy Network, and medical centers also have some very good websites. At the University of Pennsylvania, we have a website called OncoLink that is available to anyone online. Memorial Sloan Kettering Cancer Center, Hopkins, the Mayo Clinic also all have very good websites where patients get information on bladder cancer.
What's something about urothelial cancer that's not often discussed, but you wish people knew more about?
Well, smoking. Smoking is the biggest risk factor for urothelial cancer. When people think of smoking, they, of course, always think of lung cancer, but the majority of patients who have bladder cancer were also smokers, although there's certainly patients who get bladder cancer who don't smoke. So smoking cessation is very important for us to discuss with patients. Patients who have muscle invasive disease and who are recommended to have surgery think that, oh my gosh, how would I live without a bladder? They need to understand that patients can live a very normal life without a bladder, that not everyone has to have an ostomy, although you can still live a normal life with an ostomy, and you can live a good life with a urinary diversion. Something else that's not talked about a lot is after a cystectomy, sexual dysfunction is a big issue. We always think of that when we think about prostate cancer, but it's not spoken about as much with bladder cancer. In men, when they do a cystectomy, men will end up with erectile dysfunction because the prostate is moved along with some vessels and the nerves can be disrupted. And in women, the surgery can also cause some sexual issues. They remove the ovaries and cervix, which that alone wouldn't cause it, but having the lymph nodes removed and sometimes parts of the vagina can cause some sexual dysfunction. And the other thing I wish people knew was, as we discussed in the very beginning, never ignore hematuria. Hematuria should always be worked up unless there's a clear cause. You know, it can certainly be from a UTI, kidney stones, radiation, cystitis for patients who've had pelvic radiation. But if a clear cause isn't known, they really need to see a urologist and get a workup with a cystoscopy if they have unexplained hematuria, even if it's intermittent.
Thank you for those things. Those were all really great points. So just to wrap us up today, do you have any final comments about the treatment of advanced urothelial cancer?
Well, I think what nurses need to keep in mind when managing patients, that there's a lot of psychosocial issues for patients with bladder cancer. One is the cancer diagnosis, which is devastating for anyone, even for a curable cancer. The second is there may be a decision-making burden for those patients who might have an option as to what treatment to choose. There's the treatment implications, the concerns of surgery and surgical recovery and pain, chemotherapy and the side effects, sexuality and intimacy, as we just discussed. Fertility can be an issue, even though patients with bladder cancer can be older men. Some of them may still want to have children. And there's the issue of body image. After surgery, there's a scar, there may be a stoma. So patients have a lot of things to deal with after diagnosed with bladder cancer.
Well, Barbara, thank you for that. And thank you for joining me today. You have given us such great information about this type of cancer that is not one that's out in the forefront and talked about a lot, but as you said, it's number 6 on the list. So it's definitely something that nurses could experience having patients with this diagnosis and getting these treatments. So I appreciate your time and your expertise in this area.
Well, thank you for giving me the opportunity for bringing a cancer that's not well known a little bit more to the forefront.
Great. Thank you.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.